We do have Dr. Gregory Ewald here with us. He's going to be giving great presentation on that content. If you have any questions during the session, please go ahead and put those in the chat box, and we'll get to them as soon as we can. And we'll be running a poll at the end of our session for our amazing founder who will be pitching today, and that is Capella Imaging. I guess with that, I'll hand it off to Hall, our CEO, to get things kicked off.
Great. Thanks, Shane, and thank you guys for joining us today. What we're going to talk about today is thromboembolic diagnosis and anticoagulant management. And with that, we're going to have Dr. Gregory Ewald of Washington University School of Medicine give us the current state of the art in that place. And then afterwards, we'll have James Blackledge talk about a specific application of it. I think one of the questions, Shane, is the chat is disabled. If we could enable it, I think we'll get some more questions there. And with that, let me ask Dr. Gregory Ewald to introduce himself, tell us more about his work, and then tell us more about the topic of today. Dr. Ewald.
Thanks, Hall. Yeah, my name is Greg Ewald. I'm a heart failure transplant cardiologist at Washington University in St. Louis. Been here for all my career. And the topic we're going to talk a little bit about today is kind of near and dear to my heart. We no pun intended. We've managed patients, as you'll see, with mechanical devices over years, and one of the issues with those devices has been thromboembolic complications. And so we've worked on developing a product that might have implications here, and I'm going to provide some background around. Let me share my screen here around the use and treatment of patients with advanced heart failure and some of the issues associated with the device therapy. So to give you all just a little bit of background about heart failure, clearly an epidemic in the U.S., over 6 million Americans with heart failure, about 1 million new cases each year. If you look at an over 65 population, quite prevalent, causes a lot of morbidity in terms of hospitalizations, admissions for both heart failure and non-heart failure causes. Still a high mortality disease. Some of this is sudden cardiac death, which there are devices to address that problem, but patients with heart failure, depending on the severity, can sometimes have a mortality rate that approaches 30 to 50% the first year. As a healthcare, nationally in the healthcare system, we spend a significant amount of money, mostly around hospitalizations, or at least about 2/3 of that amount of money is on hospitalizations. So to provide a very broad overview of heart failure, it really kind of breaks down into management, breaks down into these categories. Clearly, lifestyle changes and modifications to a patient's day-to-day life is important. There have been significant improvements in the medical management of heart failure, such that now a number of patients that develop the condition can actually have significant improvements in their cardiac function, and hopefully never require some of the devices and things like heart transplant that we're talking about today. And more recently, some of the drugs, sacubitril, valsartan, and the SGLT2 inhibitors have been really new additions to the armamentarium in managing heart failure patients. Devices, there are devices to prevent sudden cardiac death. For patients with advanced disease, we'll talk a lot today about ventricular assist devices. So left ventricular assist devices that augment function of the left ventricle and sort of do not replace the heart, but provide a lot of support for a failing heart. Transplant has been around, as you'll see, for a very long time. It's still considered probably the gold standard for a patient with very advanced disease in terms of providing long-term quality of life and survival. And then certainly for patients that are not candidates for many of these therapies, we access and utilize a palliative care service to really try to provide some quality of life at the end of life for many of these patients. So this is a cartoon, but basically it depicts patients develop heart failure. Some people are very, very sick and have cardiogenic shock at the onset, but most patients can actually be managed medically with the drugs I just talked about for some period of time. And then many times you see patients start to have more frequent decompensations, progression of left ventricular dysfunction, and sort of they enter this kind of nebulous, yellow box here where, patients start to develop end-stage disease. It's important for us to try to intervene before they develop end organ dysfunction like renal failure, hepatic disease, other things. And this is really where, where transplantation and left ventricular assist device therapy resides in sort of the, stages of managing heart failure. To talk a little bit more about advanced heart failure. So of these 6.2 million patients, it's we probably, and I have a slide with this in a minute, but we probably are going to transplant about 3,400 patients a year. And that's really limited by the donor supply. So even though there have been some increases in donor availability over the last decade or so, we still have a limited number of transplants that can be performed each year. So really, there are probably at least 25,000 patients out of these, 6 million that have advanced disease will fall into sort of an acceptable candidacy for advanced therapies, such as a durable left ventricular assist device. And as you'll see, we're not necessarily implanting, 25,000 of these devices every year. So I think there's still an unmet need to utilize mechanical circulatory support for patients who are not eligible for heart transplantation. Heart transplant has been around for an extremely long time. So these are just a few magazine covers from the first year of heart transplantation. Chris Barnard did the first heart transplant in South Africa in 1967. Transplanted an individual from a young woman who was hit by a car and became brain dead, even though there was really not a brain dead declaration at that, it really wasn't a concept at that time. The surgical management of a transplant patient has been well worked out. It's really only after immunosuppression became very standard in the 1980s that we actually really now have become successful at doing heart transplantation for end-stage heart failure. The problem is there really are not enough donor hearts to transplant everybody who could potentially benefit from the therapy each year. So we have to be very selective in who we place on a wait list. And this is information as of today, basically. So current wait list for a transplant in the US is 3,305 patients. We're adding about 3,500 patients to that list every year. We've transplanted 2,700 to date, year to date. So we'll transplant about 3,400 patients. So we're kind of in a steady state where there are always 3,000 or 4,000 patients waiting. And yet we've really maximized the number of transplants we can do each year because of a limited donor pool. And that is really what then led to the development over the last 2 to 3 decades of utilizing durable left ventricular assist devices. So you probably remember back to the Barney Clark days and trying to augment cardiac function with a device. Well, the technology has improved dramatically over these last 20 plus years. And now we basically have a small implantable device. As you see here, this is a picture of the HeartMate III. It's surgically implanted. So it does require, an open sternotomy procedure, cardiopulmonary bypass. So it is a big procedure with a lot of recovery, but the device is placed inside the left ventricular apex and flows blood continuously to the proximal aorta. It's powered externally by 2 batteries or a wall, a wall adapter. And it's controlled by a computer controller that the patients carry around in various configurations. It's importantly utilized in 2 ways. One is a bridge to transplant. So patients who are too sick to wait any longer for a transplant, patients that have comorbidities that require some period of time to recover before they can get transplanted. But importantly, what we'll talk most about today is really destination therapy. These are patients that have been deemed not transplant eligible, partly because of maybe age, other medical comorbidities, and so forth. And so we implant these devices really as the long-term or last therapy for a patient for their heart failure. So how do we select patients for long-term mechanical support? Really, there are not a lot of absolute comorbidities or absolute contraindications, but a lot of relative ones. Age, certainly as patients get into their late 70s, early 80s, they often have other comorbidities that make it too risky. They have a lot of other medical illness with a very poor prognosis. It's not going to be addressed by improving their heart failure state, severe lung or liver disease, severe renal dysfunction, right heart failure. So the device only addresses the left ventricular failure. And so if you have a significant component of right heart failure, you're not a good VAD candidate. Patients with a lot of vascular and peripheral vascular disease, as you'll see, an active infection. If the device gets infected, it's a challenging problem to manage. We'll talk a little bit more about GI bleeding because one of the comorbidities or complications of having an LVAD is recurrent GI bleeding. So if you already have that going into the implant, it's a problem. Patients have to be able to, comply with medical therapy, come back to the office, be, very compliant patients. And so a social evaluation is needed. They have to really still have a caregiver at the beginning and kind of somebody that can help support them through this process. So there are a number of reasons why patients might be deemed not a candidate, but in general, patients who have very advanced heart failure, who are not good transplant candidates, can still be considered for a long-term destination therapy mechanical circulatory device. So really the current platforms that are out there and being utilized, or at least are implanted in patients, are these three. The HeartMate II from Abbott really has been the workhorse for many years for this therapy. It's an axial flow pump, as you'll see in a minute, in a cutaway of this device. However, at this point, even though it's still available, it's not utilized much because, as you'll see, the HeartMate III probably has superior outcome. It does have superior outcomes. It's a magnetically levitated device where, as you'll see from a cutaway, it has a rotor that does not have any contacting bearings or parts, and so has a better profile in terms of pump thrombosis, which is important to the discussion tonight. The Medtronic HVAD, very similar in terms of being a centrifugal flow pump. However, it was taken off the market about a year ago. We still have patients implanted with the device, but there are no new HVAD implants in the current climate. So the HeartMate II basically, again, is implanted in the left ventricular apex. An inflow cannula delivers blood flow to a rotor that spins via electromagnets and then ejects blood to the proximal aorta. The important point here is there's still a inlet stator and bearing associated with this, a ruby bearing that's associated with the inflow cannula that really over time we understand has been an area to propagate blood clots, and I'll show you an example of that. And so the Achilles heel of the HeartMate II essentially was, for the most part, pump thrombosis. That really the only effective therapy was really to replace the device. So another large operation in people who are significantly impaired, and so a challenging problem. This is all in the setting of aggressive systemic anticoagulation. So despite anticoagulation, these pumps were developing pump thrombosis. You can see here, as I said earlier, kind of the workhorse of LVADs. Over 27,000 patients have been implanted with the HeartMate II over the about 15 years that it's been available. there are still 3,700 patients receiving ongoing support. So we still have destination therapy HeartMate II patients in our VAD program. We still have some of these patients that are listed for transplant and waiting on heart transplantation. So the HeartMate II is still out there. And so pump thrombosis is still a concern in our HeartMate II patients. The HeartMate III, again, as I said earlier, is a magnetically levitated rotor. The motors, the magnetic motors in the housing spin this rotor at about 2,500 to 3,000 RPM. Blood flows in from the left ventricular apex, is accelerated through the chamber and pumped to the proximal aorta through the outflow graft and cannula. Again, all of these devices have a power lead connected to the device that comes out of the body, usually in the upper abdomen, connected to a controller and battery packs. But because of the, so, you know, with the HeartMate III, many are really, because it's the only device available, all of the implants currently for left ventricular assist devices moving forward are HeartMate III implants. So currently about 18,000 patients on ongoing support, and a number of patients, over 27,000 now implanted with the device. And you can see here, it's really only been available for the past 6 to 7 years. So if you look at a large data set, this is the Intermax Registry of device implants. So not everybody's required to send their data to Intermax, but I would say most large VAD programs in the country do. And so the implant volumes over time, what you're looking at here is basically a HeartMate II population in blue, a HVAD population in red or orange, and then now the HeartMate III population, the magnetically levitated device, in green. So you can see here that what we've seen is over time, HeartMate II was basically the device available. HVAD took over some of, as centrifugal flow pumps, smaller profile, and somewhat improved outcomes, took over a number of those implants. And really, since the HeartMate III trial has been completed, you can see that now almost all of the implants are HeartMate III in 2021 and beyond. The other thing that has sort of impacted the utilization of LVADs in an advanced heart failure population has been changes that happened at a national level with United Network of Organ Sharing and how donor hearts are allocated to patients on the wait list. Before 2018, there were really 3 categories of patients, and most of those status 1 or highest urgency patients had an LVAD, and there was very little way to discriminate between a sick LVAD patient and a sick heart failure patient without an LVAD. And so the Thoracic Committee came up with a set of new guidelines that were put into place in October of 2018, and now it expands this. So patients that go on the transplant waiting list now, if they are suitably ill and in shock and are being supported by a temporary device like extracorporeal membrane oxygenation or ECMO or a balloon pump, they can actually get a higher priority status for a transplant. And then the other thing that occurred around this time was to add a larger geography, so a 500 nautical mile radius around the transplant center for status 1 and 2 patients. And this graphic on the right shows how it affected our program in St. Louis. So prior to this change, we did almost all of our transplants from our local organ procurement group. So most of the hearts were utilized here, but now it brings in really hospitals from all of these areas that we can now pull from when we have a very sick status 1 or status 2 patient. So the upshot of this is that many patients that become ill can now get transplanted as a primary therapy rather than getting an LVAD, going on a wait list as a VAD patient. And so most of the implants that are being done now in terms of mechanical circulatory support devices are really in patients that are going to utilize that device as their long-term therapy. You can see here that's kind of what's happened. So prior system before 2018 is in blue, new system or current system is in orange. And you can see that, now most of the patients that are getting transplanted are getting more are getting transplanted from a balloon pump and ECMO than they are long-term durable LVAD. So this has a couple of implications, though. I think importantly, it's important to understand that patients that get a VAD now are really going to live the rest of their life with that therapy. If they have a problem with their LVAD, such as pump thrombosis or other issues like bleeding and so forth, we can't necessarily bail them out, so to speak, with a transplant. So I think it still has mechanical support, and the complications that can occur with it and what we'll talk about in terms of diagnosing thrombosis still remains very relevant in a current model, even though many more patients are now getting transplanted without having to get mechanical support. And you can see again from the Intermax Registry, same color scheme, but what this is really showing is that the bridge to transplant market for LVADs was always about 30%. There were a number of patients in the middle that had issues that had to be resolved before they could go on the active wait list, but that the intent was to ultimately salvage them or improve them with an LVAD and then put them on the wait list. That was another 25%. And then the other half of implants typically were destination therapy patients. Well, after 2018, as you can see here, continuing now, almost 8 out of 10 implants for an LVAD really are in patients that are going to live with this device, for the rest of their life. What is the survival after an implant of an LVAD? You can see here, this is basically, I haven't shown you the HeartMate XVE. It was a large device, electrical device that was the early LVAD, a poor 2-year survival. But with the introduction of the HeartMate II and then further with the HeartMate III, you can see that the 2-year expected survival for a device patient is now roughly 80 to 85%, which really rivals or is very similar or the same to what we would expect from a heart transplant recipient. So these devices do a great job at improving survival in a very sick heart failure population. If you look at longer term outcomes, this is data again from the Intermax data set. You can see that the 5-year survival roughly in a contemporary cohort, say the last 4 to 5 years. So the 5-year survival is right about 50% for an LVAD patient. Again, many of these now are destination therapy patients. So what are some common adverse events that we are concerned about? And many of these really revolve around this issue around need for anticoagulation, bleeding complications, and the possibility of pump thrombosis. So you can see here, patients still get hospitalized after LVAD, mostly for these other complications. GI bleeding is still about a 20 to 25% in some series incidence, and is multifactorial in its cause. Again, a more elderly population, angiodysplasia in the GI tract, systemic anticoagulation, continuous flow circulation as opposed to pulsatile circulation. And so GI bleeding really hasn't been impacted that much by the shift from a HeartMate II to a HeartMate III platform. Pump thrombosis has, and I'll show you that data in a second as well. So really the hemocompatibility of a patient with their LVAD is complicated. There are probably some pre-implant factors. So some patients have other causes of stroke or issues such as atrial fibrillation, prior stroke or vascular disease. But the device then introduces a number of potential issues. So gastrointestinal bleeding, there's loss of von Willebrand protein function that helps with platelet aggregation and clotting. Many patients have small angiodysplasia in the colon and GI tract. It doesn't bleed until they get an LVAD. And then the need for antiplatelet systemic therapy and systemic anticoagulation. Neurologic events can be embolic. So if a clot forms in the pump or the circuit, and that gets embolized as a stroke. There's probably some degree of vascular fragility with hypertension and other issues related to the patient's condition. And then pump thrombosis, which is the most challenging situation that we deal with an LVAD patient. And so really all of these things combine to really cause, potential for these vascular bleeding and thrombotic complications. Think about a patient with a VAD that comes in with a GI bleed. Now you have to stop their anticoagulation for a period of time to address the GI bleeding. And that may then introduce the risk of pump thrombosis or a clot that forms, in the circuit. Stroke, usually has to, certainly as a hemorrhagic stroke results in a change in anticoagulant therapy. So there are all of these factors playing a role at a given time that makes this patient, higher or lower risk for clotting and or bleeding that we deal with on an individual basis with a VAD patient. So what we started to see with the HeartMate II was this ruby bearing, as I mentioned earlier, and the stator that's connected to this, probably because of heating and coagulation of blood at the bearing site, you would propagate a thrombus that could, either stay small and local, but oftentimes we would even see a propagation of clot that would track down into the actual rotor itself and can cause significant problems. Certainly when there's substantial clot in a device, it wasn't very hard clinically to make a diagnosis of pump thrombosis. But what was challenging was really trying to understand these patients that had maybe small amounts of clot in the pump and how to best manage that. I'm not going to spend time on this, but I want to just show you that in the early days of HeartMate II management, these are the kinds of ways we had to try to understand and diagnose pump thrombosis. So patients would have elevations in power requirements. They might have an elevation in a blood enzyme that gets released when there's tearing of red cells. But none of these ways of diagnosing pump thrombosis were really satisfactory or had a high degree of certainty that the patient had pump thrombosis. We did a lot of attempts at different types of imaging, and ultimately, if a patient was really felt to have pump thrombosis, if they were still a surgical candidate for pump exchange or urgent transplant, that's how we would manage it. And you can imagine we actually ended up, having to replace a couple of HeartMate IIs in patients that did not have pump thrombosis. They had hints that they might be having pump thrombosis, but did not have that. So having a better way of diagnosing pump thrombosis became a very central attempt, both at our center and other places. And that's really when I began to work with Greg Lanza at our institution and others, our surgeons and others, to really try to come up with a better way to image clot in this complex circuit where there's high degree of shearing and blood flow, need for anticoagulation, and a background of really the blood pool, both in the heart and within the pump itself. And so we began to develop this fibrin, technetium-based fibrin-specific probe to try to better look for LVAD pump thrombosis and help us make a better decision about management of these patients, both from a pump replacement standpoint, a bleeding standpoint, and really trying to maybe even individualize the anticoagulation for some of these patients with complications. And you'll hear more about that in the second half of the hour. So this is data from the HeartMate III trial. So the HeartMate III, as it became introduced into the market, was compared to the gold standard at the time, which was the HeartMate II LVAD. Patients that were entered into the Momentum 3 trial were randomized in a 1-to-1 fashion, and there was a short-term cohort to look for efficacy, and then a longer-term patient follow-up to compare outcomes to the HeartMate III. And this is there's a lot of data around other issues with the device, but this is the bottom line: is that at least in the short-term cohort, there was a significant absence of pump thrombosis in the HeartMate 3 compared to the HeartMate 2. And it was, felt to be superior at that time for short-term support as a bridge to transplant. Now, obviously this is 6-month data. And then the other key was to really look at long-term data to see if those were held up. And this is adverse event profile in the Momentum 3 trial. So looking at some of these adverse events that we've talked about, you can see there was a significant reduction, although importantly, the pump thrombosis in the HeartMate 3 is not zero. There's still a signal of about 1.5% in the HeartMate 3 patient population. So pump thrombosis has not completely gone away. It's just reduced in its incidence from the about 14% that we're seeing in a HeartMate 2 and a long-term follow-up. Stroke, again, was reduced. There's still a baseline stroke incidence of about 10%. But when you reduce the thrombosis and embolic stroke rate, it was reduced significantly from the HeartMate 2. Bleeding, again, however, was unfortunately about the same. So, still about a 25% incidence of GI bleeding in a HeartMate 3 population, and just a little bit higher than that in the HeartMate 2. So GI bleeding, has not been significantly addressed by changing to this magnetically levitated continuous flow pump, the HeartMate 3. Driveline infections, pump infections, right heart failure are still relatively similar between the two pump platforms. So I think there's still, an unmet need in terms of how do we best manage these patients with these devices, both from diagnosing potential pump thrombosis, from potentially looking at clot that still forms either outside or within the outflow graft that still requires surgical revision. We still manage patients by monitoring LDH and trying to do device diagnostics and CAT scans, but certainly a fibrin-specific probe, like you'll hear about later, could definitely add to to the device or to the ability to diagnose these issues. And then it also may help us individualize the anticoagulation management. So there are patients that have ongoing bleeding despite changes in anticoagulation and their VAD therapy, that we sometimes have to interrupt for very long periods of time, or sometimes even forever, their systemic anticoagulation. So if you had a way of really looking in the pump, so to speak, to look for clot, it may help you then to individualize that person's anticoagulation. You might be able to see patients that are at very low risk of thrombosis and thrombus complications, and patients that are at higher risk that need even higher intensity anticoagulation. So I still think we don't, even though the pump platform is improved, there's still ways to improve the therapy of these long-term now DT therapy HeartMate 3 patients. And then if you think about thrombus in other forms of cardiovascular disease, clearly there are a lot of opportunities. So unstable angina, myocardial infarction, we think is a clot within the coronary artery. Typically, we have to do an invasive procedure to make this diagnosis. Could you have a more simple way of looking for clot acutely in patients that present with these coronary disease issues? Left ventricular thrombus in patients with heart failure is very poorly imaged with echocardiography. Could you have a better tool? And patients still present with stroke and other systemic emboli from having LV apex thrombus. Atrial fibrillation is extremely common, and many times we have to look for clot in the left atrial appendage using transesophageal echocardiography before doing procedures like cardioversions. Transesophageal echo, although not super invasive, still requires anesthesia and requires a probe to be placed in the esophagus. So a simpler way of looking for left atrial appendage clot prior to a cardioversion would be desirable. And then patients that are out there with mechanical valves, the question sometimes comes up about valve prosthetic clot. Transesophageal echo is again used for that, sometimes fluoroscopy in the cath lab. So looking for clot on a prosthetic valve would be helpful. Venous circulation clots, so DVTs, are very, very common, often diagnosed somewhat vaguely with ultrasound. A DVT that actually travels and causes a pulmonary embolus can be a life-threatening or life-ending complication of DVT. And those are typically diagnosed with CT scans that require high doses of contrast. So patients that have contrast allergy or contrast or significant renal dysfunction are not good candidates for a contrast CT. So there's probably opportunity to look for fibrin in the pulmonary arteries and diagnose pulmonary embolus as well. So these are sort of outside the scope of tonight's talk, but I think other opportunities for a fibrin-specific probe like you'll hear about. So in summary, advanced heart failure is going to continue to be a prevalent problem. Destination LVAD is still a good, durable improvement in quality of life and survival in very selected patients. We've talked about hemocompatibility with these devices and bleeding that limits the complication-free survival in these patients. And so ways to diagnose pump thrombosis, to tailor anticoagulation to impact bleeding complications, I think will be an addition, a welcome addition to this patient population and therapy. And so I'll stop there and answer any questions that you might have.
Great, thank you for that. We had several questions come in the chat box. The first is about animal hearts. What's the state of animal hearts? Are they coming on the scene anytime soon, or do you think they will ever come on?
Yeah, so you probably saw the first xenotransplant was done in a human in the last year. I think, early successes, but there are still clearly barriers to that being a viable therapy for transplant. I think eventually they will be, ways to genetically engineer these organs to the point where some of the complications will be mitigated. So I think it will potentially, add another viable way of transplanting patients. But I think we're probably still, at least a decade or more away from that becoming a commonly utilized therapy.
Great. Next question is, you referenced power elevations. Can you tell us more about what that is?
Yeah, so really the only thing that's directly measured in the device is the power that it's consuming. And so there's a flow estimator in the device, but it's all based on nomograms that assume how much power the device is using. So the device, that controller that I showed that sort of sits outside the body, is constantly monitoring power consumption by the device. So as you can imagine, if there's clot within the system, increased friction of the rotor to turn, there's increased power consumption, and these power spikes essentially that we would utilize as a potential marker for pump thrombosis.
Great. Is the thrombosis pump-induced or a condition of the patient's medical state?
All the above. So I think, again, patients can have atrial fibrillation. So, clot could already be in the body and ingested into the pump. I think that, as you saw with the HeartMate II, a lot of it was device related. So this bearing that would, I think, heat up and cause coagulation and shearing of blood cells would sort of trigger and start the clotting cascade. But then, the body takes over and expands a clot very readily once there's clot in the system. So there's really factors, both patient factors, device factors, and then intensity of anticoagulation factors that all combine to determine if a patient's going to develop clot.
Great. And isn't there a whole industry of sensor manufacturers for non-invasive detection of clots?
Yeah, I guess I'm not totally familiar with that, but I think certainly trying to understand not just if there's clot in the system, but where the clot is residing, and localizing the clot with imaging is still an important factor for us.
One of the early issues with LVADs was that they would actually shred the blood cells and decrease capabilities there. Is that still an issue, or is that behind us now?
Not completely behind us, and that's still why we monitor lactate dehydrogenase. It's an enzyme found in red cells, and so if there is shear, and so even a HeartMate 3 patient with probably an improved flow through the system and no bearings in the system, even a HeartMate 3 patient will have an LDH level that's modestly above normal. So there's always a little bit of shearing of red cells. And certainly that gets promoted when there's less laminar flow, once there's clot in the system. But there's always a little bit of shearing that goes on with these devices.
In the next generation, what are we going to see? Smaller devices, better devices, or cheaper devices? What is the angle that most people will take on the next generation?
Would like to see all of the above, but I think the devices have gotten quite small. So I think, there might be opportunity to implant what's been called partial support devices. So it's devices that might even be able to go into an arterial, into an artery and not have a surgical implant. So I think that's still a possibility. It's been investigated or promised for a long period of time that these devices could be fully implantable so that we could put the battery, at least a small battery pack, and the controls for the device inside the body and mitigate the amount of infection that goes on due to the fact that there's a drive line coming out of the body. So I think those would be sort of some of the technological improvements that would still be available. It's a bit concerning that, we're kind of down to one manufacturer of a device right now. So I think, the competition that is often fueled by, by having multiple people in the field. I think we've seen a little bit of a little bit less of that over the last few years.
Great. The last one is a question. Wireless communicating sensors should be able to measure what the body feels due to a problem. Whole panel results could be immediately sent to the patient's physician. What's your comment on that?
Yeah, I think, in the heart failure space, there's been there's ongoing work in sort of looking at, looking at ways of diagnosing volume status, of diagnosing rhythm disturbances and other things with wireless communicating sensors. And so I think we'll still consider, we'll still see that. I mean, you see some of it with even wearables like smartwatches and others. So I think there will be, an ongoing refinement of that. Even in the VAD space, now when we used to have to interrogate an LVAD, it was with a bedside monitor. Now the device can talk to, via Bluetooth through an iPad to download data and so forth. So there have been improvements in the wireless capability of managing heart failure, and I think that will continue.
Well, you spurred one more question, and then we'll move to our next presenter. Has the legal framework winnowed the field of device manufacturers? Is that why there's only one?
Yeah, I don't know. I mean, again, we had, we certainly had multiple. It's a big investment. These trials are big and expensive. And certainly I think as the companies that were engaged in doing this, so Abbott, the HeartMate was basically old Thoratec, bought a couple of times, St. Jude, then Abbott. And I think as these device companies have become part of a bigger framework, oftentimes I think those companies aren't, it's only part of their development cycle. And so I don't know if it's necessarily the legal component, but it's you can see it's maybe a more modest niche of patients for a company like Abbott than it used to be. I mean, Thoratec was completely invested in this therapy, and now it's a small part of what Abbott does. So I think that's part of the issue as well.
Great. Thank you for that presentation. And with that, let's go ahead and bring up James Blackledge of Capella. James, if you could tell us more about your work and what you're doing and kick off your pitch as well.
All right, thanks, Tal, and thanks, Dr. Ewald, for the presentation. I'm the CEO and president of Capella Imaging, and we are taking the fibrin targeting technology that Dr. Ewald mentioned that came out of the Washington University School of Medicine and trying to commercialize it. And that's what I want to talk to you about today. So let me get my screen going. Good. So Capella Imaging, we're a small startup company in St. Louis, Missouri. We're developing our lead candidate is a product we call FibrioScint, which is a nuclear imaging agent that is targeted to blood clots. Our leadership team here at Capella has a combined experience of over 100 years in drug development. And FibrioScint is a remarkably universal imaging agent. It binds both acute and chronic thrombus, venous, arterial, in the presence of anticoagulants. It's really a remarkable product. So what is the problem that we're trying to solve here? As Dr. Ewald spelled out here, thromboembolism is a problem, and it's a growing patient segment, especially with these patients that require mechanical support devices, whether they be in the form of ventricular assist devices or prosthetic valves. And venous thrombosis affects 900,000 people in the U.S. Heart disease is responsible for 20% of the death in the U.S. Sudden death is the first symptom in 25% of people with PE. I find that a remarkable statistic. And while there are a lot of tools out there now that are effective for imaging thrombosis in various forms, there are still a number of either unmet or unserved needs. And we think that we can address those with FibrioScint. So perhaps the most challenging of these indications is VADs, as we were just discussing. These are very high flow rate devices with a lot of shearing. They're high levels of anticoagulant, and so this is really our worst case scenario as far as we're concerned in terms of getting an image for clots in vivo. And what you see here is an image of a VAD that was removed from a patient that came into the hospital for pump exchange. And we took this pump and we implanted it in a 70-kilogram calf, which we use as our model for a human system, and acquire the images of that removed VAD. And so the really important thing I want to stress here is that this is as close as you can get to a clinical model with preclinical data. This is a human pump with a human clot implanted in an animal of similar size, weight, and flow rate as you would find in a human patient. And we can very readily image these. And the very bright spot you see around the neck of this device is a thick layer of clot that has been deposited. So we've done all of our preclinical work to advance this product to the clinic. And the thing that I really want to stress again, most drugs fail in development, making the transition from preclinical to clinical, either due to efficacy or toxicology. And as I explained in our previous slide, our preclinical model is really as close as you can get to clinical data without filing an IND and getting into humans. Additionally, it's a nuclear imaging agent, and so it uses exquisitely small amounts of material. And in fact, we're only required to do a single species of toxicology. We have already completed a GLP toxicology study, gotten a completely clean bill of health. So this is FibrioScint has been highly de-risked in both of these regards. It's a classic saying, things don't translate well from preclinical to clinical. We've cured cancer in mice many times over. This is a really good model to predict that this is going to be a very successful product in terms of imaging in the clinic. So it's a growing market. The use of mechanical support patients is growing each year. And these are some numbers that we've worked out that are fairly conservative in terms of not the actual total addressable market. This is the part that we think we can capture in the first year. And it represents the U.S. sales of about $160 million. And again, these represent indications that are either unmet, for instance, ventricular assist devices. There's no other way to image clot in these pumps because of the challenges of doing it with a metal device. But there are other underserved indications like clotting with prosthetic valves. Now, right now, those can be imaged with transesophageal echocardiography, transthoracic echocardiography, but those are often ambiguous results and need to be followed up with multiple imaging modalities to actually get a strong diagnosis. Furthermore, those technologies cannot distinguish between clot and pannus, which is a fibrous growth. And that's kind of a critical distinction because presently the only way you can distinguish those two situations is with surgical intervention. FibrioScint can do it with just a single image. Now, as like the initial indication, let me back up and expand on this a bit, is these unmet and underserved medical needs. What we hope to see is that, you know, for equivalent cost and equivalent time, we get the door open, become the first pass choice for diagnosis for some of these things. For instance, pulmonary embolism. There are aspects of pulmonary hypertension that have a thrombolytic component. There's chronic esophageal hypertension. You know, these are areas that are notoriously difficult to diagnose in terms of the clotting component. And we think we can play a very strong role in these. And once we get your foot in the door, it becomes, you know, the chance to say, well, look, if I have the potential need to follow up with the second imaging modality in the first place for the same cost and time investment, why don't we just use this as the first pass indication? So our competition in this space varies depending on the indication. As I said, with VADs, there currently is no method of diagnosis. It's a completely unmet medical need. Prosthetic valves, our competition is the current standard of care, which involves various different imaging modalities, and you usually have to use multiple ones to get any sort of firm diagnosis. And again, you can't distinguish between these two conditions of thrombus versus pannus. Pulmonary embolism, you know, our competition is currently the standard of care, and that works reasonably well, actually. In fact, the sensitivity, you know, we would have extremely high sensitivity with our product. Sensitivity is not necessarily a challenge with the current standard of care with pulmonary embolism, but it is with pulmonary hypertension. And again, you know, we think we can work in that field, and once we get the door open, we can take a chunk out of the first pass diagnosis. We have a strong intellectual property position. This was developed in the laboratory of one of our co-founders, Dr. Greg Lanza, working with Dr. Ewald. Washington University owns the intellectual property rights, and we have the exclusive license to develop this and market it through Washington University. We've been working with a GMP manufacturer to develop a scalable commercial process for making this. And in that process, we've identified a number of structural improvements that are going to permit us to extend this patent protection. But we have a very good intellectual property position with this. So our development plan timeline, right now, we're trying to raise $1.5 million that will allow us to file an IND and get into patients. We're already working with Certis International, which is a contract research group that is very strong in nuclear imaging to prepare our IND and submit it. We will follow that up with a $3.5 million round next year that will allow us to actually start trials. Ultimately, we want to raise $8 million in 2025 to do our phase 2 trials. And the current feeling of our key opinion leaders is, you know, this is an imaging agent, and you get essentially a binary response. So the numbers that you're used to seeing in a clinical trial of having hundreds of patients so that you can power it enough to move this curve and generate a statistical response isn't necessarily part of this. And so the numbers involved in clinical trials of imaging agents are significantly smaller. And it's likely that we will not be required to do a phase 3 study if all goes well. Our path to market would be, we want to, you know, file and get approval on our new drug application. We would obtain reimbursement code for healthcare providers. And Capella itself would manage the manufacturing and packaging of the product, but we would partner with a third-party provider such as North Star, GE Healthcare, or Curium, who happens to be across the street from me right now, for taking advantage of their pre-existing network for distribution and sales. So the investment we're seeking, we're looking for right now, at Q3, early Q4, a $1.5 million investment in convertible notes at a cap of 11 million. That will provide us support to get IND approval and to initiate clinical trials. We'll need 3.5 million to follow on with that in Q2 of 2024 to complete clinical trials. That's going to allow us to manufacture material, do the trials, and also, kind of an important part here is to build out our business function a bit within Capella Imaging itself. This valuation is based on the $10 million Series A and a $1 million investment by North Star Medical Radioisotopes, which funded all of our preclinical activities. And some examples of other comparable deals in the nuclear imaging space here on the left, where Cardinal Health acquired Lymphoseek for 310 million, Curium with Zivacor for 400 million, and this Full Life Technologies for FocusX for 245. So, if you put all these numbers in, we think it's an attractive offer that we're making here. So this is the team at Capella, myself, Dr. Lanza, Dr. McGee, and Grace Coy from the Washington University. Bill and myself have a tremendous amount of experience in drug development. We've spent each of us, north of 35 years at this point doing drug development, from discovery all the way to commercial, and an assortment of big pharma to the large companies. Greg is a well-regarded cardiologist and also has pharmaceutical drug development experience. And Grace brings a very strong background in radiosynthesis and radio labeling for the development of this product. One of our strongest assets, though, and you've already heard from one of these folks, Dr. Ewald, is we have a world-class team of medical advisors, Barry Siegel and Sally Schwartz, both of the Washington University Medical School. These folks are household names in molecular imaging. Sally actually wrote a lot of the guidance documents for the agency in terms of filing INDs and NDAs. Of course, Dr. Ewald introduced himself. Dr. Zaharias is the professor of medicine and director of the Valvular Heart Center at Washington University and is working with us on the prosthetic valve indication. And Dr. Schindler is a nuclear radiologist who is going to lead the efforts for actually acquiring the images once we get into the clinic. And that was my last slide, so I would be happy to answer any questions in the little bit of time we have left.
Yeah, so my question is, you're working on the FDA path. What's the very next step that you have to put in for the FDA as far as what exactly are you putting together as the next deliverable or submission?
So we're working on preparing our IND as we speak. And so we want to put that together and submit it and get approval. And there's always give and take in this. We're asking a couple of things. For instance, in phase 1 is typically healthy volunteers. We want to do a cohort of healthy volunteers up front and then transition for a phase 1B, if you will, to actual patients, bad patients, prosthetic valve patients, and actually get some images. But these things have to be negotiated. But that's our next step, is to file the IND and seek approval.
Well, you talk about an exit at FDA approval, but also the potential of going into the market. If you go into the market, how would you sell this product, or what kind of sales force would you put together for it?
Well, again, that's, our intent would be not to build a sales force. We would like to work with, Curium and Cardinal both come to mind. They've got portfolios that they sell these things. They sell nuclear imaging agents, and truthfully, our hope would be that they would acquire the asset, that they would be interested in it enough to acquire the asset. But we want to plan for, we want to have a go-to-market plan, and we would want to take advantage of their existing network rather than try to create our own.
Great. The last one comes from the audience about why not use the techniques in the Fantastic Voyage movie, but without the people. Seems like there's nanotechnologies that are getting close to being able to go through the bloodstream to do the imaging from the inside out. Where do you think that is in the current life cycle?
Oh, goodness. I'm trying to remember the movie, actually. I know the concept.
They shrunk a submarine down, and then they went through the blood cells and was
Yeah.
able to do the imaging from inside.
Yeah, I'm really not a little clear on the question. Whether you're thinking of a nanoscale device that is actually remotely manipulated, or on a certain level, we are on a nanoscale. It's what we have is we're delivering a very small molecule that is seeking out. This binds very, very quickly. It is extremely high avidity, and it's completely cleared from the background in 30 minutes to an hour. So yeah, I'm not sure how to address the idea of a remotely controlled device. Yeah, I don't see that happening anytime soon.
I was thinking of a nanoscale delivery system. There's plenty of those now for therapeutics, but if there was something in there that could be measured from outside, it changes different shape or size based on the condition it finds inside. Would that be a helpful solution down the way? I don't think we're going to shrink a submarine anytime soon, but the idea of nano delivery systems that would aid in doing the imaging, I guess, is the question.
Yeah, well, so one of the challenges here for a lot of these other imaging modalities is sensitivity. And, so even, this sounds like what we're talking about here is a novel way of finding and binding and perhaps sending a signal, but sensitivity is the challenge. And with nuclear imaging agents, the sensitivity is just exquisite. So we are looking for, potentially clots that are hidden away in veins and arteries and are difficult to address with the current less sensitive means. So this is intriguing, but there would have to be some way to get similar sensitivity from that approach.
Great.
Could you just speak to, like, I don't know, maybe I missed it, but say a VAD patient that would get serial studies. So like dosing of the nuclear material, is this going to be an issue if patients needed serial studies over multiple years, say, for instance?
Well, so the way we envision this is that it's really a maintenance tool, and on a first pass, our thinking is patients that are in a high risk population, VAD patients, prosthetic valve patients, would get screened with FibrioScint immediately upon implantation, and you've got a baseline. This is the level of thrombus in this person, and all these patients get some form of anticoagulant treatment. So you come back in, and maybe it's something that you wean off of a bit. Maybe it's every 2 months, 3 months initially, but we envision it probably every 6 months a patient would come in and get an image. And so in terms of the gastrointestinal bleeding, as you talked about, the challenge is even with the HeartMate III, which has got reduced stroke risk, there's still high levels of anticoagulant, and you can't really afford to titrate that down because the risk of a stroke is severe. It's potentially fatal. So if you had a tool that would allow you to say, well, look, we're not seeing any sign of thrombus buildup, we're going to titrate you down a little and keep an eye on it. Now you've got a tool to address the effectiveness of anticoagulation. There's not a challenge of repeat exposure with the radioactivity. And the mass of material that we're dosing, again, you're not even typically required to do repeat dose toxicology like you are with traditional pharmaceutical or escalating dose. We would never come to a pharmacological dose. So
Good.
Yeah, that's one of the beauties of my background is oncology, and and it's a completely different story with those sorts of drugs where you're given large amounts. With these nuclear imaging agents, toxicology is just really not a concern.
Great. We're at the end of our time. Dr. Ewald, did you have any closing comments you'd like to make?
No, I don't, I think again, we talked a lot about mechanical support, but within the cardiology space, I think there's, significant areas where thrombosis is clearly prevalent, and this is exciting, potentially an exciting tool, I think.
That's right. James, any closing comments from yourself?
I'd like to thank everybody for their attention, and if there's any interest, please reach out. And yeah,
we'll do so. We'll follow up with the investors that we'll send it to and get next steps with it. Appreciate your taking time to share that with us today, both James and Dr. Ewald. Appreciate your time, and of course, we'll make this recording available to you for whatever purposes you have as well. With that, we'll go ahead and thank our audience for coming today, and with that, we'll go and close it out for tonight, and see you guys next time.
all right. Thank you very much. Have a good evening.
Thank you. Thanks.
Okay.